Good afternoon, everyone, and welcome to the Utah Infection Prevention Collaborative. These sessions are here to help you better navigate through this challenging healthcare crisis. Leading the presentation today will be our infection prevention specialist, Martha Jaworski from Comagin Health. And also part of our expert panel is Dr. Alan Nakashima with Utah Department of Health HAI program, Christy Grimes with the Utah Department of Health, and we also have Ali Spangler with the Utah Healthcare Association. Welcome, everyone. Just a couple of housekeeping details. We have the Zoom attendee controls up for you to see, so you know where you should see the presentation, where you can share your video when the time may come for that, how to mute yourself, and how to enter in questions in chat. We are asking for you to use the chat feature to submit any questions that you may have during the presentation. And last time we actually had a really great conversation going with ideas and resources and contacts shared. So we encourage you to freely use chat so that we can continue to build a learning community through these sessions. If you want to share something anonymously, you can also do chat to me privately. And as you're chatting in, if you select the option of all panelists and attendees so everyone can see your comments, that would be great. So first to start, if you could just let us know who's on the webinar today by entering your name and building into the chat. And if you're attending in groups, if you could let us know all the names of the folks that are with you, that would be great. So your cameras and microphones will be off during the presentation as well. And we're gonna have some pauses for polling and a question and discussion session a little bit later. We can also unmute you to share when we get to that part of the session. And we just want to make sure you know the meeting is being recorded and it will be available following the webinar. So just a little bit about Comagin Health for anybody who's on the call for the first time. We are the Medicare Quality Innovation Network Quality Improvement Organization in Idaho, Nevada, New Mexico, Utah, Oregon, and Washington. And we work with providers across the spectrum to develop and apply strategies to deliver better care and better health at a reduced cost. And we're delighted to be here with you today and really appreciate the Utah Department of Health HAI program for sponsoring these sessions. Next slide. Just to give a little background for anyone newly joining us today, essentially what we are doing here is we're trying to provide needed training and materials on infection prevention practices, and it's tailored specifically to the needs of assisted living and intermediate care facilities. Also to address any gaps that might be there in your building with your COVID-19 pandemic preparedness. Next slide. Our asks of you during this presentation is to actively participate, join us for sessions, use chat, and again, make sure you're chatting to all panelists and attendees. I see some names coming in. Thank you very much for those of you getting us started. Ask questions when we have our Q&A time. Please share your challenges and experiences. We're all learning together, so we really want this to be a good learning community for all. And at about session 6 to session 8, we're going to be reaching out to you all individually to check in and make sure that we're hitting our target with the information we're providing and make sure that we're just giving you good information that this is worthwhile use of your time. And Martha gives a little assignment from session to session for you to just practice some new things. So we ask that you make your best effort to do the weekly recommended assignments and just test out some things in your building. And we really commit to you that we are here to get relevant information to you, provide an opportunity for you to learn, get your challenges and questions asked and met, and just really work together on this. That's what a collaborative is for. Next session, or sorry, next slide. Okay, so we have a quick announcement in that our next week's session is going to be held in concert with the Utah Healthcare Association at their conference. So it's going to be a different time next week. It's going to actually be 9:00 a.m. on Wednesday, August 19th, and we will be sending around an invitation and a Zoom link to you. And the topic's going to be on personal protective equipment. So we encourage all of you to come to share with your colleagues and learn with us next week. So thank you very much to the Utah Healthcare Association for hosting this event at their conference. Next slide. So again, just to give you a little bit of a background with the session schedule, we've had a kickoff on July 29th. August 5th, we've had the basics of controlling respiratory outbreaks. And today we're going to be talking about management of individuals with suspected or confirmed COVID-19. If you're new on the call and have not yet gotten our recorded sessions for July 29th and August 5th, please put your contact information into chat and I will follow up with you to make sure you get the recordings and to get the tools that we discussed in the first sessions. Next slide. Okay, so we have a polling question. And so, per the CDC, within what time frame should you notify residents, families, and staff of a positive COVID-19 case? Again, these are anonymous, so your name won't pop up in there, but please give us your best guess. All right, so it looks like most of us went with 24 hours, and I'll let Martha let you know what is the correct response, because I'm sure that's going to be in our education today. Okay. All right, Lisa, any more polling questions for us? All righty. Next question is, how often should residents that have been exposed to COVID-19 be screened for symptoms? And again, this is anonymous. Take your best guess, please, and let us know. I'll give you a few more seconds for that. All right, so we have every shift winning out on the answers. And again, I will let Martha provide you that information in the session. All right, and I think we are ready to go with our next part of the training, which I will turn things over to Martha Jaworski. Martha, you ready?
Yes, thank you, Shannon. Welcome everyone today. Shannon said I'm Martha Jaworski. I'm a Senior Improvement Advisor at Comagine Health. And we're going to be talking about what happens when you get a case. So next slide, please. So we'll start with a brief check-in from last week. And then we'll look at what should you do, what are the very first steps you should do with new cases, talk a little bit about transferring, potentially cohorting or having a COVID-19 unit as a possibility, communication, so communicating to staff and residents and families, and then a little bit on admissions and a brief discussion of what we'll be talking about next week. Next slide. So I want to echo what Shannon said. I want to thank everyone. There was very good active chat last time, and I'd love to see that again. So we talked last time about the chain of infection and how transmission-based precautions can break the chain as well as source control. So if you want to, and we sent out a PPE audit tool. So if any of you have had any experience with that, or if you have any concerns about transmission-based precautions and your ability to do that, if you can chat in, that would be great. Also chat in any other issues you might have related to infection prevention in your organization. So again, encourage you to use chat. Next slide. So I'm just going to start with definitions. A confirmed or suspected case is just that, any resident or staff member that tests positive for COVID-19 disease. So that would be a PCR or molecular test or the antigen test, not the antibody test. So the diagnostic test for COVID-19, or if they have symptoms consistent with COVID-19 disease, would be a suspected case. And then observation or quarantine is for residents that have been exposed or potentially exposed to COVID-19. And these are, for example, residents that have been readmitted from a hospital admission or have had an exposure to staff or another resident. Next slide. So step one is really notifying public health. And so if you have suspected or confirmed COVID-19 with residents or personnel, also if you just have severe respiratory infection where you are sending someone to the hospital, or this small cluster of 3 or more residents or facility that develop the new onset respiratory symptoms in that 3-day time frame. So those are the criteria for notifying public health. Next slide. So you want to contact the local health department at that email listed there, and that is actually a state, sort of a communication center that will designate to your local health department that you have a case. And this is important. The actual test results are reported through the laboratory, but since you're in a congregate living situation, you also need to report to them so that they can help you with identifying the next course of action. And they can potentially arrange or direct you to testing for COVID-19 as needed. And then there are just a couple of links there for the for direct contact for your local health department. And an action item for you, if you don't have this kind of readily available and right on hand, you want to get those that information totally just ready to go, because once you get that positive, you will want to act it really immediately. Next slide. So no matter what your situation is, you want to isolate any of these known positive or suspected and using the transmission-based precautions. That's kind of step one. And then you want to be making sure you have universal source control. So other residents are isolating in their room, distancing and wearing masks as appropriate outside the room. Their personal space. You want to be canceling any congregate activities and suspending visits. And this you can follow your state policy, which is on the next slide. So this is right out of the, I think it was the June 22nd, the more recent guidance on assisted living visitors. So they do state that you have to be free of COVID-19 to allow visitation. And to resume visitation, you need clearance from the HAI program, as well as adequate testing and adequate personal protective equipment. So you will need to stop visitors when this happens. Next slide. This should be looking very familiar to you. Gloves, gown, eye protection, and a face mask for an N95 respirator. So you need those on hand for any positive case. And if you want to chat in here on any PPE supplies that you have any problems obtaining, we can start a little discussion on that. Next slide. So one of the first steps you want to look at is, can that resident's needs be addressed and can they remain in the facility? So obviously you're going to transport to the emergency room if that's the case, but looking at their situation and whether you can manage them. And we're going to talk a little bit about the possibility of a COVID-19 care unit. That's the ideal situation. Full PPE for staff and source control, single room if possible, and consider moving residents. Consider this with caution and probably not doing that until you are consulting with your local health jurisdiction, but is there a way to move residents to minimize exposure and possible transmission? And then you can consider halting admissions to the facility. Next slide. So what about roommates? Roommates are typically considered exposed if their roommate, tests positive, and they need to be on their own 14-day quarantine after the last exposure. And they may be permitted to share a room with other exposed residents, but you need to keep them separated by PPE. So in other words, not using the same PPE on 2 exposed residents. Next slide. So this was one of the questions, you want to increase monitoring to at least every shift. I think most people got that. And then counsel residents to restrict themselves to the room. And this would be everyone in the vicinity of the positive case. Consider using transmission-based precautions for all the residents until there are no new cases. And then this notification piece, you want to notify your healthcare personnel, your residents and families. And definitely be taking more of an eye and looking around at your basic infection control practices, such as hand hygiene or PPE use or environmental cleaning, and just making sure you're really on top of those basic control measures. And we'll talk more about testing later, but testing is also part of the picture there. Next slide. So you also want to be responding to any COVID-19 positive staff members. If the staff worked when they had symptoms or 48 hours prior to symptom onset, you want to test any asymptomatic staff. So any asymptomatic staff are priority for testing. And then they cannot work until they've met all the return to work criteria, which I have a link to here from the CDC site, and there were some fairly recent changes to that. Then identify residents exposed to the COVID-19 positive staff and place them on observation, which is full PPE. And I'd also identify other staff exposed to the COVID-19 positive staff. And then you can use the risk assessment to look for need for work exclusion. And that is the your Utah set of 3 algorithms for assessing risk is a very good risk assessment to do in this case. So, yeah, you want to make sure, the other point I was going to make here is that staff in break rooms sometimes can expose other staff. So it is very important to really evaluate if your staff had a non-PPE exposure situation with the positive staff member. Next slide. So if testing is available, how it's going to work is you're going to test all symptomatic people, and then you can consider testing asymptomatic residents and staff who are exposed. And that would be kind of the next tier. And then the last one is whole facility testing or just further evaluation for infections among residents and healthcare personnel exposed. So it's all based on availability, and that can shift over time. So in this situation, you'll be directed by your local health jurisdiction. Next slide. So this is actually a nursing home recommendation, but I think it's a very good one. They recommend you notify healthcare personnel, residents, and families within 12 hours and provide them with education or handouts. Also maintain frequent communication with residents, families, and healthcare personnel about updates on the situation. And the next slide has this is an example of a template notification letter. It's from the CDC site, referenced at the bottom there. What I like about this one is you can it's a Word document, so you can take the kind of body of it and modify it to whatever you want it to say. But it's maybe a little easier to start with something. The recommendation too that I have is to have this set up and ready to go. So you just put in your number of confirmed cases, and that will make, when you have to act on this, it will be easier that you have it set up and ready to go and know kind of what you want to say and have an idea of what your plan is. Next slide. Another thing to consider with information for staff, since many staff do work at more than one facility, you can ask your staff to notify any other work locations that you had a positive case in your facility. And you may have another communication system in place for this, but if you don't, then your staff can take responsibility to make that notification. You also want to be explicit about any additional PPE requirements or plans to move residents. And then inform staff that there may be testing, or maybe you know that there will be testing. And I have here just a note that, because I've heard this on many calls, that staff have, and residents have the right to refuse testing. So you might consider a policy on how you manage test refusal. And I tried to look up a sample of this and really couldn't find anything, except that you can, have them not come to work for a certain period of time or something along those lines. But just be aware that that is something that can come up when testing, when you expand testing. Next slide. So this is from the assisted living CDC site. Of course, after you initially do your notification and contact public health, you're going to be evaluating whether that resident can remain in your facility. So these are some things to look at. Can they do their own ADLs? Are they able to isolate in their room? Is it somebody that can stay in their room? Have meals delivered? And just be checked regularly with staff. And then can they request assistance as needed? So that is their recommendation for that evaluation. Next slide. If people do require more assistance, you have to evaluate whether you're able to provide that. And again, can they remain isolated? Can your on-site or consultant personnel manage their level of care? And do you have your PPE and training? Next slide. So now I'm going to talk a bit about COVID-19 units. And this is something you may never have to do or participate in, but it's a possibility in at least some assisted living facilities. So I'll just go through a few slides of what that looks like and what kinds of things you want to look at. So a COVID-19 unit is basically a separate area, a separate location where you're putting COVID-19 positive residents. You also want to develop a staffing plan so that your staff are dedicated to that group of residents. If it's planned in advance and you have the ability to create space, that is an advantage. And then when you have cases, if you already have cases, public health could come in and assist you in creating that space and new movement of residents to reduce exposures. And just when you're thinking this through, consider what if you have 2 cases or 10 cases or 20 cases, how might that look different? And can you have flexibility in where you start such a unit? Next slide. I like this as a visual. This is from the NETEC, which is the National Emerging Infectious Pathogens, I think, Training and Education Center. It used to be National Ebola Training and Education Center, but clearly other pathogens are out there, so they renamed it. But they basically did a kind of a red, yellow, green to show. It was in the context of a COVID-19 unit, but I like the fact that it's kind of a visual to show the different types of situations that a resident can be in. So they could just be COVID-19 positive, whether they have symptoms or not, they are positive. And then you have those suspected residents where they may have symptoms, you don't have the test back. And then you have the exposed category where you do contact tracing and you see, yes, that resident was exposed here. And then you also have this unknown category where maybe it's a recent admission, You don't really know the history of where they've been. Maybe they went out. Maybe they had, went out of the facility, and you may be wanting to quarantine them after. So no known exposure, but they're in that gray area, literally. And then the last is the kind of the new normal, which is no exposures or recent trips out. And then on the right, it's just where they kind of land and how really they all have to be separated from each other, but they're sort of in a hierarchy, if you will. So just for reference, I like the visual of this. Next slide. So one thing you want to look at with a COVID-19 unit is space. So you want it to be separate from other rooms, preferably a separate floor, wing, or cluster of rooms. And then the ideal is to have a separate area for staff. So a separate work area, restroom, break room. I added this one, but you want to evaluate the airflow in the area and make sure that you're not putting the way your ventilation system works is going to work for the location of those rooms. You definitely want signage at the entrance, and you want to limit entry to that area, and that is recommended signage wording there. Next slide. This is just an example of a floor plan. We talked about this in the first session when we talked about risk assessments and having an infection prevention plan. So it's if the Department of Health comes in to help you with your outbreak, they will like to see an updated floor plan of your facility. So this is where you can visualize potentially where a unit might be. They'll look at where the exits are, where you might have space for staff, and how you could potentially move residents if needed in your facility. But this is really a key part of your plan and your emergency preparedness. So if you don't have this yet, we recommend you get that. And then the other thing they can do is when they're doing their investigation, they can be looking at where the positives are to both staff and residents to identify trends and who else might be exposed. Next slide. So you want to dedicate staff to that unit. Have as few people, if any, beyond them coming into there. The staff have to be trained. The other thing is to bundle care activities. This is kind of a workflow recommendation. So try to organize your care such that you're not going in and out of these rooms frequently. Next slide. And then obviously we're going to try to keep this area as clean as possible. High touch surfaces at least each shift. I'd recommend more frequently than that if you can. Also dedicate equipment into that area and consider having nursing staff or care provider staff assist with high touch surface disinfection in rooms with the appropriate training. Next slide. So if you cannot keep a COVID-19 positive resident in your facility, you may consider in advance of having a case to identify what options you might have. There are, for example, some nursing homes, but they're going to be on a case-by-case basis of whether you can, your resident would qualify for that. So are there other options for where a resident can go? Also just considering what symptom and severity criteria there has to be for a resident to move into a certain area, like a certain nursing home. They might have to meet that criteria. So just a few notes on that. And then the CDC site has some information on alternate care sites. Next slide. So this is just a little bit more on testing. You want to test your symptom. You're always going to test symptomatic healthcare personnel and residents. That's always the priority. And then as you have more testing, you can go wider. If you're not able to test, you're going to be putting everyone on quarantine and doing full PPE until 14 days after that exposure. So again, if you do have adequate testing, you could do facility-wide testing, and that will give you a really good idea of any asymptomatic or pre-symptomatic residents that you have. And then there is some testing information from Utah site here. Next slide. So if you do need to transfer, these are just some considerations for transfer, COVID-19 positive resident. And this would be done in consultation with your local health jurisdiction. So you want to make sure that where you're sending them is matching what their needs are. You want to notify all the transport personnel and the receiving facility of the suspected or confirmed diagnosis. And while you're waiting for transfer, you need to already have that, that isolation and sort of segregation in place. So you want them in a room with the door closed, with healthcare personnel using PPE. And the resident, if they can, should be wearing a cloth face covering, particularly when out in a hallway or during transport. Next slide. And this is the infection control transfer form for Utah. You can certainly write in COVID-19 as your other, and this is nice because you can show what PPE has been being used, what their symptoms are, and all the other information on here. Next slide. So if you have testing results upon admission and they're positive, and you have a COVID-19 unit, that's where they should go, or the single room isolation. Then the negative admission test, you go ahead and observe them anyway, because a negative admission test is really only good for the day it was taken. So you still want to be looking at them for the 14 days after admission as that observation time, that incubation period. And then after the 14 days since their last potential exposure and they remain symptomatic, they can move into a room with a roommate or out of an observation status. And you can test at the end of that if you have adequate testing to kind of make sure that that potential initial exposure didn't result in a positive later on in the incubation period. Next slide. This is primarily, I think, a nursing home categorization, but this is from the Utah hospital discharge. So if you are accepting someone from a hospital, you may have a similar set of criteria, but if you have no clinical concerns, you're going to consider that observation and quarantine for 4 days, private room if possible. If they have a negative test, but there's a question, you might retest and continue with transmission-based precautions until they're discontinued. So if you recall, there have been some changes to those discontinuation of transmission-based precautions recently. So you can consult that. If there's a pending test, the recommendation is they not be transferred until the test results are available. So if there's any update on that, maybe Dr. Nakashima can let us know about that. And then patients with a positive test, again, you would admit to the COVID-19 unit and leave them in the transmission-based precautions until that can be discontinued. Next slide. So we're going to shift gears a little bit. This is sort of in preparation for next week. Next week, we're going to be talking about personal protective equipment use. So I just want to introduce this idea of the burn rate calculator. I believe there is one being developed in Utah, but this is an example from the CDC. There's a little tutorial for how to use it, but basically what you enter are your number of boxes of PPE type available each day. So full boxes of PPE, gloves, gowns, eye protection, face masks, and N95 respirators. And then you also enter your number of suspected or confirmed COVID-19 residents. And I think really what you want to enter is your residents requiring full PPE in this, but someone can correct me there if I'm wrong, because what you're really trying to get at is how fast are you going to be going through this and how many days do you have left of it. And then that's what you enter every day, and it will calculate your burn rate. So how many, what percent of a box or how many boxes are you going through every day for that population that you have entered in there. Next slide. And then if you have PPE shortages, I suspect many of you are already using extended use. Obviously, face masks, right now, the expectation is you're wearing them all the time. So you're not, my guess is most people are not throwing out a lot of face masks, regularly, but you're leaving them on your face for longer periods of time. And same with eye protection. It's either left on or disinfected. Any issues you have with PPE shortages, there's a Google Drive document on local health contacts for PPE that is listed there. Next slide. Okay, here's several resources from today's presentation. And next slide. Okay, we have polling questions. Lisa will be getting those up. There they are. So same question. What's the time frame for notification of residents, families, and staff of a positive case? All right. So that one looks like it flipped a little bit from the first one. That's great. So again, the 12 hours, it is a nursing home recommendation, but one of the complaints that you hear are frustrations from families is not knowing what is happening. So I do feel that this is a really important part of this communication piece is an important part of how you manage any case number. Next question. So often should residents that have been exposed to COVID-19 be screened for symptoms? Great, so you do want to increase your monitoring, really of anybody that could potentially have had an exposure. So once you have a case, you just increase that monitoring really throughout. Okay, and then next slide. So next steps, we kind of talked about these as we went along. Make sure your contact information for reporting a positive case is readily available and that you have also local health jurisdiction contact information. And then modify or develop communication to residents, families, and staff, have that ready to go so it can be sent immediately. And also have a person, see if you can identify a person that takes responsibility for that particular piece of it, that communication piece. And we'll talk more about this later in the series. And have a plan to move and or transfer residents. If you have a positive test, take a look at your floor plan. Consider identifying alternate care sites or just thinking through how you could make that work with the roommate situation, your resident population, and your floor plan. Kind of trying to put that all together and think that through before you're in the situation where where everything's happening fast. So next slide. I think that is all I have. Okay, we can open up for questions.
Wonderful, thanks Martha. And while folks are kind of formulating their questions in their mind. I just wanted to turn things over for a moment to Dr. Nakashima to see if there's any announcements or updates or anything that she would like to share as we kind of, or anything that you want to comment on from this presentation.
This is Alan Nakashima. Thank you again for that great presentation. You know, it is important for you to, as soon as you have a COVID case, to contact the Utah Department of Health. We're going to have a session in September about the services that we can help you with when you're responding to a COVID outbreak. It is pretty complex, and so it's good to get some help. You know, get that hai@utah.gov email someplace for you to access easily, so you can contact us. The other issues are that we're constantly putting out guidances on our website. Not exactly easy to find, unfortunately, but if you go to the Utah coronavirus webpage, you can see where it says case counts, and then you can go to information for, it just asks, it says, there's a ribbon that says information, and then if you click on there, if you look under information for healthcare providers, that's where a lot of our guidances are posted. This week we're going to be posting one for some of the facilities that are receiving antigen testing machines. CDC and CMS has begun distributing antigen tests to facilities, and so we had a lot of questions on that. So we developed a guidance for that. And then the revised infection prevention and control guidance will probably be up there in the next few days. And that, again, is a summary of the newer guidances that have come out, so that we're just due to get everything sort of consolidated in one place for facilities. Those are my announcements, and if there's any questions, let me know.
Great. We actually did have one question. I'm scrolling down about the recommendation for molecular versus antibody blood tests.
Okay, so these tests are a little bit different. The molecular test is PCR, and what it's trying to detect is the RNA from the virus. And those tests are very, very sensitive. So if you know, even if you have a little bit of RNA from the virus around, it will test positive. And that's actually one of the issues that we often have when somebody has had COVID, and then we're trying to clear them from isolation or from hospitalization, for example. And so what happens is that as you recover from the disease, you may still have small amounts of remnant RNA. The virus is no longer there, full virus, so there's no transmissibility there, but there's this little bit of RNA that the test will still detect. So one of the ways that we try to sort this out, or we have in the past, is using the antibody test. So now the antibody test is a test to detect the antibody that your body creates in response to infection with COVID. Now those tests are not quite as perfect as PCR, so they're not quite as sensitive or specific as PCR. So there's some issues with antibody testing. We think that only about, at any given time, 70% of people who have had COVID in the past will actually test positive on an antibody test. That doesn't necessarily mean you don't have any antibody if you were infected. It just, that's the limits of the detection from the test. And also because as time goes on after you've had an infection, there's natural, what we call waning immunity. That means your body just naturally stops making the antibody because it's not needed because you're over the disease and you're not getting exposed to it again. But if you get exposed again, for most people, that antibody will kick in, and your body will start making more antibody, and you'll be protected from a future infection. But so for these people who have prolonged prolonged positive PCR tests, we sometimes do an antibody test to see if they did make antibody to the virus, because that gives us added assurance that probably the patient really doesn't have viable virus that is going to actually transmit to anyone. Now, that said, the CDC in the last couple of weeks, or maybe it's been about 2 or 3 weeks now, put out guidance looking at all the studies that have been done so far to look at whether those prolonged PCR positive patients are actually infectious or not. And based on that, they put out much simpler guidance that is time-based and symptom-based criteria for taking people out of isolation. And those criteria are what we're going with now, because the evidence is pretty good that if you meet the time-based criteria and the symptom-based criteria, you're probably not infectious. There will be exceptions though, so we can't say it's 100%, but it's pretty good. So, you know, I think that as we learn more about the disease, we'll be able to make those distinctions better. But, you know, we have one case right now, for example, one nursing home that has a couple of cases in it where it's been more than 90 days since those people were initially infected, and then they become positive again. And then, is that a new case? Well, we're treating those two as new cases because it's been so long, and CDC sort of recommends that if it's that long, we should treat them as new cases. So we're putting them in isolation according to the guidance, and we won't take them out until we get the symptom and time-based criteria met.
Great, thank you, Dr. Nakashima. I'm asking Martha if she could pop the symptom-based guidance into our chat, but if for some reason we can't grab it in time for this session, we'll make sure that we send that out along with our resources and recording and slides for today.
Yeah, sure, I will look that up right now.
Thanks, Martha. I'm not seeing a ton of questions in chat, so I just wanted to bring up a question that maybe Christy or Ali could address, because the issue of residents and or staff refusing testing came up a little earlier in the presentation. So I'm just wondering if there's been any kind of regulatory guidance or any kind of policies that we know of that people have developed in assisted living when those situations come up that you guys can comment on.
Christy, I don't know. I think you got to address the regulatory. I know we've seen this. I think most of our facilities that I've talked to just exclude those people for 14 days, you know, because they don't know what to do with them. They're going to just assume that they're positive. But they don't, I don't know about a regulation about that. Is there a regulation, Christy?
There is not a regulation as far as refusing testing. What I would encourage people to do is make sure that you're communicating and explaining why that testing is so important. I know that people still think, well, I don't have it. I don't have any symptoms. I don't need to be tested. And especially for staff, but I guess also educating family members or residents who say, I feel just fine, I don't need to be tested. That the reason, a big part of the reason that we're testing is to find out who might be asymptomatic and might be spreading this virus to other people. And just making sure that families, residents, staff who initially are saying, no, I don't want to be tested, understand their responsibility to help protect others in their working or living situation.
Thank you, Christy. That's great insight, and potentially we could help with putting together something for just that purpose. Because you're right, when somebody feels fine, they have a lot of questions about why you want to take an uncomfortable sample from them potentially, if it's you know, the nasopharyngeal one. But so that, I think that's great, a great point.
And the other time that we see this often is when we are doing a serial point prevalence surveys. And so when we're, and this will come up in that September 2 presentation, when we're trying to separate infected from uninfected people in a facility, we're doing that so that we can stop transmission. So we want to protect those uninfected people and keep them that way. And that requires what we call serial point prevalence surveys. That means we have to come in there every few days to retest until we get no more positives. And while we're doing that, that's where I see the people have a bigger objection to getting tested, because it's so often. It could be as often as every 5 days or whatever, depending on the situation, for us to go in there and retest to see that separation. So I think that's where I've seen the most objection. But again, it's absolutely necessary if we're going to protect uninfected from the from developing disease, because this is a very vulnerable population. And so if they do get the disease and then develop symptoms, many of them will go on to require hospitalization and even die. So that's why we do those.
Okay, we've had a couple questions. Oh, I'm sorry, did I interrupt someone?
Well, this is Christy. I just had a couple of things that I wanted to mention. I don't know if you have the ability to put the coronavirus.utah.gov website up. I think that would be helpful, or I could share my screen. I'm sure I have it up.
Yeah, hang on just a second, Christy. I'm putting it right in. Tell me if this is the right one. I'm putting it in chat.
Yep, that's it.
Do you want to share your screen though? Is that what you're suggesting?
Yeah, you're welcome
Yeah.
to. We can.
Okay.
We
I
can do
just
that.
think that sometimes it's easier to direct people where to go. So are you able to see my screen?
So let's see. I think you need to. Did
Not
you click on
yet.
share screen?
The green button at the bottom. Try that. I can try to share mine. I have it up right now. Would you like me to do that? And you can.
Oh, there we go.
Oh, there you go. You got it.
Okay, so this is the coronavirus website, and this is where you will find a lot of information and guidance. And I'll just walk you through where to find that. Information for, go down to healthcare providers. And then if you scroll down, resources for healthcare professionals, there's where all the guidance has been posted. So if you're wondering about specifically assisted living or visitors in assisted livings, guidance for healthcare workers and any type of long-term care, I would just encourage you. I have this saved on my desktop. I use this all the time. Things are changing as we know more about the virus and as more guidelines are put out. I would just encourage you to keep that up on your screen. The other thing that I wanted to mention was, as you're planning your what to do when you get this virus, and if you determine that you don't have the ability to do a COVID unit and you're looking at alternate sites, it's not appropriate to send someone to the emergency room and just dump them. That's happening, and our hospitals are not set up to take people who don't need acute medical care. So if you have someone that is asymptomatic, test positive, and you know you do not have the ability to care for them and keep the rest of your building safe, make sure that you're reaching out to these other designated facilities. So one might be City Creek, one might be Coral Desert down in southern Utah. Contact these facilities directly. Do not dump the patient in the emergency room and expect the hospital to take care of it. Please contact, I'll say City Creek because most of you are from the northern part of the state. City Creek will determine if they have the availability to take your asymptomatic resident. If they do, they will direct you to make sure that resident has seen and been evaluated by your medical provider, a physician, within 12 hours of admitting into City Creek. Now that might mean an emergency room visit to make sure that they get that evaluation before they go to City Creek. But please make 2 phone calls if that type of situation comes up. Call City Creek, discuss with them, do you have the availability, and then make the phone call to the emergency room if City Creek does and say, hey, I have a COVID positive asymptomatic resident. This resident has to be evaluated by a healthcare practitioner, and I'm sending this resident to the emergency room for that evaluation, and they are already approved to come to City Creek. So I just want to make that clear that your plan is not dumping people at the emergency room and saying, I can't keep them. That's not an appropriate discharge plan.
Thanks, Christy. And we had a request to pull up the Utah site again, so I'm asking Lisa if she might be able to kind of click on that since she's sharing her screen. Thank you. Great questions. And again, we'd love your feedback on anything that we can cover, that you know, any burning questions that you have, any topic areas that really you would like to learn. These are your sessions and we want to make them valuable for you. I want to just do a couple of quick announcements because we are at pretty much the top of the hour. Look for an invite from us for our next session, which, to remind you, is going to be held in concert with the Utah Healthcare Association convention that's happening over the next couple of weeks. It will be a different time, 9 to 10 a.m. So we will send you the Zoom meeting link for that, and please join us and tell your colleagues. We'd love to have folks join us there and learn. I also wanted to quickly do a couple of announcements, and I'll send these out to you separately, but one thing we had shared last week were just a couple of Utah-based resources. There was an announcement that we received on conversation cafes, which look to be virtual activity sessions or virtual activity kind of resources for your activity folks at your building. There's one coming up this afternoon, and I think also next week. And there is also an opportunity through a group called Utah Strong for support for stress and anxiety and whatnot. And it didn't specify, so I'm imagining that might be also for staff and for residents, and a pen pal writing opportunity. So we're going to make sure that you get those resources as well. This is a sharing environment, so anything that you're able to, that you'd like to learn about, or any information, that we all kind of bring to these, I'd love to just share back and forth so that we're all learning together. Again, we're at the top of the hour, so I'm going to thank you all for being here today, and we really thank you for your efforts during this very challenging time. So this concludes the Infection Prevention Collaborative webinar for today. Thank you for attending, and we will see you next week.